And welcome. Yes, you are listening to Three Women, and we are, as always, or almost always, live. And today we're talking about something that's going to affect all of us, some of us a little sooner than others, perhaps, but cuts to healthcare in the province of Ontario. And I'm delighted to have on two amazing women in the course of the hour. Doris Grinspun, who is the CEO of the Registered Nurses Association of Ontario, celebrating their 90th anniversary this month. And then a little later in the show, Natalie, Mehra, who's the Executive Director of the Ontario Health Coalition, who's really built that up over the last 14 years. Of course, before we even start, I want to give a shout out to our amazing techs, Lisa, Zoe, Diane. We have a room full of women bringing this magic to you. But let's talk about health. If you want to tweet in any questions, any concerns, please do that. It's at CHERIDINOVO. That's the Twitter handle. And that's me, your host, Sherry DeNovo, MPP Parkdale High Park. Doris, are you there?
Yes, I am here. Good morning, Sherry.
Good morning, Doris, and welcome to Three Women. So we're talking health cuts, and I just want to read you a couple of quotes. This is from the Ontario Medical Association. They have said right off the bat that by the Ministry of Health's own estimates, demand for medical care will grow by at least 2.7%. And the government is only willing to fund 1.25%. Does that mesh with what you're experiencing?
It matches, but I take the comments from the OMA a bit with a different twist. The demand of aging population, growing population, does not necessarily mean that we need tons of more money. What it means is that we need to transform the system. We need to transform the system to make it community strong, to make it health promotion and disease prevention. So, for example, something that is very dear to your heart and my heart, social determinants of health, we need to ensure that we all can continue to live vibrant lives in the midst of our communities. So lesser reliance in hospitals and stronger primary care. And that's where we're pushing the government also to ensure that the role of nurse practitioners, for example, becomes fulsome, that community health centers, nurse practitioner-led clinics are funded to its fullest potential, that we use fully and expand the role of registered nurses, for example. And the minister, in that sense, did listen to us. And he and Premier Wynne announced the RN prescribing will move forward. Now we need to push that it moves forward fast. And we need to build up home care also. So not to say that hospitals are not important, they are. But if we want to have, Sherry, as you know, vibrant communities, we also need to build the other side of the health sectors, which is community, home care, primary care, public health, the role of public health nurses, etc. So, and we need to tackle the issue of physician compensation, which many shy away, and a bit hence why the OMA is so upset also, because we cannot continue to increase the budgets of the OMA ongoingly of doctors and then expect that we will have money for all the rest. So pharmacare is a must, that we do pharmacare for this country, and why not to start in this province? The minister speaks a lot that he supports pharmacare. We, the nurses, fully support pharmacare. Let's use Ontario as the example and let's launch pharmacare. Let's remember that Canada's healthcare system was started in a universal way in Saskatchewan by Tommy Douglas. So why not to start pharmacare right here at home in Ontario?
You touched on a lot of issues. One of the things that the OMA is also saying, though, is that the biggest part of the cuts is actually to the family health teams, which are the interprofessional teams of healthcare providers, including nurse practitioners, registered nurses, everybody else, social workers, dietitians, as well as physicians. So are you not feeling the cuts? Because we're hearing about nurses being fired. The government's response is that they've hired more nurses than they're firing. You know, where's the reality in all
we
that?
We are feeling the budget constraints in especially smaller hospitals where very unwisely and no different that happened in the late 90s. Hospitals are replacing, in some instances, registered nurses with registered practical nurses or with unregulated workers simply because of lower salaries. And we do know, Sherry, that patients will pay on health outcomes because the link between registered nurses and better health outcomes is very clear. It has been there for decades in terms of the research evidence and clinical results. And so that is absolutely and wisely. And yes, what I am saying, though, is that we cannot tackle only hospital care, that we need to focus on primary care. And the government did put a halt on expansion of family health teams. We are saying none of the interprofessional models could be put on hold, not community health centers, not nurse practitioner-led clinics, and not family health teams, because interprofessional care, again, delivers better results than solo practice.
Mm-hmm. The OMA also says that they put on the table to freeze their fees if the government funded growth in the sector.
Well, you know, I said to you that that's why I take a bit with caution the concerns of the OMA. When funding goes up and up, the OMA doesn't say much about what's happening to the rest of the system. We are saying the physicians are extremely well compensated. In fact, some of us are proposing that, and the RNAO is one of those, that physicians should be compensated with excellent salaries, not fee-for-service salaries, the same as nurses and any other healthcare professional in this province. Mm-hmm. And then let's have everybody on salaries and use everybody to their fullest potential.
Which was always Tommy's aim and model.
Absolutely.
What does I think that people would be shocked to know, but what approximately does the average physician make now in Ontario? Do you have any idea?
The minimum after all expenses, if they have an office, the minimum is $150,000 after all expenses. And they can reach, family doctors can reach up to $300,000 also, and many do. So they are fairly compensated. And what happens here is that the OMA has been treated differentially for many, in fact, for always, I think. And all of a sudden, when they are told, well, you are fairly compensated, they're looking not very positively. Now, I don't know all the details. I'm sure there are other aspects that easily government could give to the OMA that do not have necessarily a financial meaning, right? Like, for example, full utilization of family health teams and allowing them. There is a problem with solo doctors that want to move to interprofessional teams. They have a great deal of difficulty doing that because of artificial barriers put by government. Let's tackle those and let's allow doctors in solo practice to move to interprofessional teams. I mean, it is absurd that when a person needs a family doc that works in a solo practice in a weekend or in a time when that doc is on vacation or ill or etc., or in a conference, that person actually doesn't have where to go and needs to go to a walk-in clinic. Every doctor should be working in interprofessional teams, and we all should be working in interprofessional teams because that's what delivers best care to people and the best access.
Now, so what you're saying is, because the OMA is clearly saying that the biggest part of the cuts is on the family practice, you're saying that's kind of not absolutely accurate, or?
Oh, I don't know if that's totally accurate. Yeah. I mean, let's not talk about what specialist physicians make, because you have seen, I don't need to tell you, and that's all the issue of should the salaries of doctors or the compensation, should OHIP billing be public without obviously disclosing names of patients or anything. And again, we are saying, yes, it should be public, the same as the salaries of nurses and any other public servant or any other health professional that makes over $100,000 is public. Let's put those that make more than $100,000 also public. Why not?
On the sunshine list, of course.
Yes.
Okay, so going forward, what should the government be doing, Doris?
Well, in our view, the government should be strengthening significantly, much more than what we are doing, and yes, it's happening, but much more, community care, starting with anchoring the system in primary care, linking that primary care also upstream with social determinants of health, which will mean tackling seriously the issue of poverty in our province, right? Tackling seriously and with timelines and with targets the issue of homelessness. Because what makes us ill, right, is not only genetics, as today people talk and talk, it's actually living in poverty or environmental issues. So let's tackle those seriously. And I think the government is attempting to do that with the climate change consultations and initiatives and with the poverty plan plus homelessness. But let's put real targets and real money there so that we end this shameless situation in a country and in a province as rich as ours. Then we should be building primary care, the first entry to the system, home care, the first entry to the system. Let's strengthen not-for-profit care. Let's stop medical tourism, which really is what will destroy hospitals in this province.
Explain what that is, because listeners might not understand medical tourism.
The people will be shocked to hear, because we were shocked, Sherry. On 2/12, we heard from a nurse that one of the big downtown teaching hospitals, UHN in Toronto, was having agreements with other countries, Libya and Kuwait specifically, to treat their people for money, which means then you can have anybody here saying, oh, I have money, or I will sell my car and I will pay and get ahead of the line with the weight of their wallet instead of with the necessity of their health. And once you allow that to happen, simply you will not be able to keep universality, access for everybody based on needs. So we, since 2012, have been pushing government, and about 6 months ago, the minister did put a hold for now on medical tourism, saying, no, you cannot market anymore, no, you cannot enter into new contracts anymore. I will review all the contracts that exist, and then I will decide what to do. We're saying there is nothing that needs to be decided except of absolutely putting a legislated ban on medical tourism. And believe it or not, you would not be surprised that the Francelina and the NDP are absolutely behind us on that. But you would be surprised that the PC actually also is asking a complete ban on medical tourism. So we have the nurses saying stop, the doctors saying stop, because Doctors for Medicare are with us on this. Ontario midwives saying stop, because they are with us on the coalition. Community health centers saying stop. And you have the two major opposition parties saying stop. We are saying now to Minister Hoskin and to Premier Kathleen Wynne, we want a legislated ban on medical tourism, because we will destroy Medicare as we know it if we don't.
Absolutely. I mean, this is the not so creeping edge of privatization, really. It's to go back to where you'd like to see the healthcare system going. And you talked about the social determinants of health. I mean, now we're, of course, dealing with Toronto, which is the center for inequality in Canada. So to speak, we have the highest rates of poverty, homelessness, etc. And it's only been getting worse in the last 10 years or so. So that area is a real problem. One of the promises that we heard the government make a while back that doesn't seem to be coming to fruition is about dental care. Has the RNAO anything to say about that?
Yes, we believe, of course, that dental care, the same as medications, pharmacare, should be universal based on needs. Now, dental care, at the very least, for people below a certain income level, you cannot be living on 25,000 a year, right, and have kids and everybody with healthy teeth. You can't, right? So we are saying absolutely we need to improve dental care. We are also saying we need to actually move with pharmacare. So the government they had done cuts to dental care at one point, and the government did then increase again or return the investment on dental care care for children. So that is very good. What we are also urging government is to keep an eye on the privatization, for-profit care, on all those aspects when it relates to programs that are for children. That are some of the programs, as you know, were in hospitals for complex issues with dental care. We are saying keep an eye, because once you start to privatize, you privatize a bit here, you privatize a bit there, then you have no handle. As quite frankly, the government didn't have a handle on what was happening on medical tourism until we raised the alarm bell. And then we issue a freedom of information, and then everything started to come out.
Now, I can imagine the hospital saying, though, but, what else are we supposed to do? We're fundraising to beat the band. We've had a freeze on our budgets forever. Where are we supposed to find the money? What do you say to them?
I will tell you where. I will tell you there. Expand the scope of practice of RNs and let RNs, RPNs, pharmacists, everybody work to their full scope, whether in hospital or in primary care, and then you will have a much more effective and efficient health system.
And does the OMA support you on this, Doris?
The OMA supported us on the issue of nurse practitioners and their scope expansion. They supported us, or at least were quiet, but supported us at the end on the nurse practitioner-led clinics. I don't see any reason, if the OMA, for that matter, the RNAO, my own association, or any other association, Sherry, if we are serious about putting Ontarians at the center, whether they are healthy or whether they are ill, whether in a hospital or whether in the community, right? Then we need to all be also equally serious about scope expansion and full utilization of every healthcare professional. We cannot speak from both sides of our mouth and only worry about that. So that's where you will get deficiencies. And that's where then you will be able to not increase budgets hugely, right? If we start to really all work to their full potential and expand scope. And RN prescribing, which I understand finally we will be moving now with it, you will see the change. We have over 100,000 RNs in this province that work across all sectors and work in all corners of Ontario. Just imagine if in addition to the work they do, they were able to prescribe within their scope of practice, of course, rather than needing to wait for someone else, the access that the public will have to the health system. How is it possible that you can take a Tylenol in the middle of the night if you need in your house, or other type of, very simple medications, and yet in a hospital you can't, and that RN, if it's not written in the PRN notes, can also not give it. It makes no sense. How is it possible that I know exactly when a child has a ear infection, but yet I cannot prescribe a simple first-line antibiotic? How is it possible that when an elder person in a nursing home has a urinary tract infection, a urine infection, and you can deep think and easily know if there is a urinary tract infection, we cannot even do that test. We cannot even then prescribe the first-line antibiotic if it's needed, or anything else that is needed. We need to send the elder person or the resident to the hospital, to emergency room, which you wasted money in ambulance. You many times receive that person confused after because they didn't provide enough liquids and hydration for that person, because that's not the priority in an emergency room, right? And sometimes they even come back with the pressure ulcer because, again, people in an emergency room didn't have time to turn that patient or that older person that needed help. And the list goes on. Mm-hmm. When that could be happening in the nursing home by the RNs and with nurse practitioners, with now again, the government did listen to us on that and is putting nurse practitioners in nursing homes, which will make a huge difference.
Mm-hmm. We're speaking, by the way, if you're just tuning in here on Three Women, to Doris Grinspun. She's the CEO of the Registered Nurses Association of Ontario, and has been in that position, I don't know, for a million years. You haven't been there the entire 90, though, have you, Doris?
You said that I was turning 90, so that's close. I'm 62, but you know what? The association is turning 90 this year. By the way, I do invite all your listeners to come on a Saturday, I believe it's 18 or 19, but the Saturday is in our website, www.rnao.ca, to listen to a very important panel on end-of-life care, which again, as you know, with the federal court decision, with the Supreme Court decision, is a tremendous, important policy discussion in this country. Please feel free to come. It's open to the public. It's free of access. All you need to do, you need to register in the website and come and hear Carol Gore is moderating, and then we have 4 tremendous panelists, including the wife of Dr. Lowe.
Wonderful. Well, Doris, just one last question, because of course you're on the show called Three Women, and you've been working with nurses. And now not all nurses are female by any stretch, but do you think that the fight that you've had to get nurse practitioners, to get expanded scope of care, et cetera, has anything to do with the fact that we're mainly dealing with a body of women?
I would suggest that at the inception of the profession, of course, yes. Of course, yes. Including, if you think, even up to I would say, quite frankly, up to SARS. You may remember how much my colleagues and I screamed during SARS that SARS was not gone, that people would continue to fall ill or worse, even die, if we took the precautions out. And that nurses in their own workplaces sometimes, and government at the time in 2000 and when it was 2002, end of 2002, didn't even listen, right? That has changed a lot, thankfully, but we are talking not so long ago, and I can assure you that if all those women had been men, they would have been listened. Yes, I believe that. There is still, Sherry, to this day, and I'm not complaining that nurses and RNs and NPs, NPs, yes, I am complaining. They are not well paid, by the way. And we did speak with the minister. They're paid significantly less NPs in primary care, for example, versus NPs in hospital care. 20,000 less in primary care. So the issue of compensation parity is a big issue for nurse practitioners. They are paid much less than in Alberta. But at least we are listened a lot more. We are respected hugely. I cannot say a word about that. When we had the issue of Ebola and the nurse became ill in the U.S., basically I took the phone and spoke with Minister Hoskins, and let me tell you, within 2 days, things were moving and directives were being given. So I want to believe that this is not an issue of this government versus that government, but that finally things have evolved, and nurses are not only loved, because we have always been loved, but also respected for the expertise we have and the contribution we make to society and to people and to patients and to everybody.
Well, that's a wonderful way to end. Thank you so much. I've been speaking to Doris Grinspun, who is the CEO of the Registered Nurses Association of Ontario. We're talking about healthcare in Ontario, the cuts that are looming, and what we're all going to be doing about it, some of the answers as well as some of the problems. Thank you so much, Doris, and happy 90th to the organization. We'll be tuning in on the 18th and 19th. Thank you.
Just before our love got lost, you said, I am as constant as a northern star. And I said, constantly in the darkness, where's that at? If you want me, I'll be in the bar, on the back of a cartoon coaster, in the blue TV screen moonlight. I drew a map of Canada, oh Canada, with your face sketched on it twice. Oh, you're in my blood like holy wine. It tastes so bitter and so sweet. Oh, I could drink a case of you, darling, and I would still be on my feet. Oh, I would still be on my feet. I am a lonely painter. I live in a box of paints. I'm frightened by the devil, and I'm drawn to those ones that ain't afraid.
Right here, right now, every day. CIUT 89.5, Toronto. Sound of your city.
Welcome back to Three Women. Of course, that was Joni. We wish her well. She's not feeling well these days. And we're talking about wellness. We're talking about healthcare in Ontario and possible looming cuts. We were talking to Doris Grinspun from the RNAO. And by the way, we love to hear from you. So keep the tweets coming at CHERIDINOVO. Sherry DeNovo, I'm your host, MPP Parkdale High Park. And right now we're lucky to have Natalie Mehra on the line. She's the executive director of the Ontario Health Coalition with 70 local chapters, more than 400 organizations represented across Ontario. And Natalie's certainly been building it up over the years. She also sits on the board of directors for the Canadian Health Coalition. Natalie, welcome to Three Women.
Thanks for having me.
So I was just talking to Doris about possible healthcare cuts. What's happening? How do you see healthcare in Ontario these days?
Well, we really have a very serious problem now. We've been growing increasingly concerned year after year as we're seeing very serious hospital cuts happening. This year is by far the worst year that we've ever seen. At this point, Ontario's hospitals have had their global budgets frozen for the last 3 years. And what that means in real dollar terms, so if inflation is increasing at about 3% per year, it means in real dollar terms a 3% cut each year. So you compound that, you've got a 10% cut over the last 3 years or so. And before that, for 5 years, global budgets were increasing at less than the rate of inflation. So they were seeing real dollar cuts then. So really we're now in the 8th year of real dollar budget cuts to hospitals. And each year, the cuts just bite deeper and deeper into services that people need. And at the same time, we're about 20,000 beds short for long-term care beds. That's like nursing home beds for people. And home care is very severely rationed, and home care funding has just not kept pace with the hospital cuts. And so really what it amounts to as a whole picture is just an erosion in the scope of publicly covered healthcare services, and people are left suffering if they can't afford to buy care themselves. And most people really can't afford the high cost of private care. That's why we have a public healthcare system.
Well, Doris talked about, at least in part, the increasing privatization, talked about medical tourism and, the toll that's taken. Now, it seems steps are being taken to address that. One of her suggestions was to expand the scope of care for nurses in hospitals, that they should be able to do some of the basic jobs that I guess now only an MD can do. Is that part of the solution?
I think so. I think everyone working to their full scope of practice is important. But Ontario now funds our hospitals at the lowest rate of any province in the country. And I say that because it underlines that these are choices that we're making and that there really is a budget problem. We fund healthcare as a whole at the lowest rate in the country, and we fund our hospitals at the lowest rate in the country, and so that's why we're seeing cuts. And yes, well, nurses working to their full scope would help. Still, programs and services are being cut everywhere. Wards are being closed down. Even entire hospitals are being closed down. And, we need a solution that takes into account that the hospitals and our health system need enough resources to provide for the population's need for services.
The government seems to respond every time they're asked in the House about cuts, nurses being laid off, et cetera, hospitals not getting the money they need to keep various services open. They respond with sort of, but we've poured more money into the healthcare system than any other government, but we've hired more nurses, but we've... what do you say to that?
Well, we have less nurses per capita or per population than we did 10 years ago. And so, part of it is just sort of playing with numbers. If you use nominal numbers, there's no context for them at all. The way to measure whether or not we have as much nursing care as we did 10 years ago is to measure the amount of nursing care provided per patient. And there is a study from CIHI, the Canadian Institute for Health Information. So that's the National Statistics Gathering Center for the federal government. It relies on government's numbers. So these are the government's own numbers. Ontario has the least amount of nursing care per weighted case, so that's per average patient, of any province in the country. And that's by far. The average is 48 hours, and Ontario has 42. So that's a very significant reduction in nursing care. And over the last few years, it's just gotten worse. So, in fact, while we may be increasing the number of nurses, we're not increasing the number of nurses as fast as the population is increasing, and not enough to keep up with the number of patients. And so, they're just kind of playing with the numbers. The bottom line is that nursing care has been very dramatically cut in Ontario, but so too has personal support, all of the support functions in the hospital, which hospitals rely on, the delivery of food, the movement of the patients, or portering the movement of patients around the hospitals. All of that has been very severely cut. Operations have been cut. Surgeries have been cut in different hospitals. Emergency departments, in fact, all hospitals are being closed down. So very, very, very serious cuts.
Now, the OMA is sort of fighting back on their, of course, for their own membership. They've said that, they got to take it or leave it offer. They say that the government threatened that if it didn't agree with the cuts, they'd move ahead without them and cut even deeper. And they're complaining that's not a partnership. Now, I don't think the average Ontario loses a lot of sleep about the income of doctors. We heard that it's quite high. Do we pay doctors too much? Are doctors somehow, should they be on a salary? What do you think?
Well, definitely other payment mechanisms. Salary with public governance would be more ideal for sure. But I think at this point, the issue with the doctors is that the government is trying to roll back OHIP billings, and that is good in the cases where they're being misused. Where physicians are billing too much, or for procedures that aren't happening, or for unnecessary procedures, and so on. So I think the best way to sort of target that in the short term is to really target appropriateness. We are seeing areas where there are physicians making, $750,000 or almost $750,000 a year through billing OHIP, and in addition to that, are billing patients for services, I think unlawfully, under the Canada Health Act, which says that patients shouldn't be paying for services that we pay already in our taxes. So we should not be paying out of pocket for cataract surgeries. We shouldn't be being told that there are measurements that are necessary that are going to cost us hundreds of dollars, or cataract surgery shouldn't be commingled with medically unnecessary lens implants that cost thousands of dollars. Patients are really being given, I think, manipulative information about that. And this is from the doctors that are billing OIP the most of all doctors. So I do think that there are areas in which there are abuses that are happening. I think that there are definitely areas, particularly in the private clinics, where approximately somewhere between 10 and 20% of tests are medically unnecessary, but physicians are billing for them, and so it increases their income to order unnecessary tests. Definitely dealing with appropriateness without cutting needed care would probably improve care and save money.
Now, one of the issues that's always plagued us in Ontario is the lack of real ombudsman oversight over our hospitals. Government's made moves to kind of have a different sort of ombudsman set up with hospitals. One of the standard complaints we hear in constituency offices, and I'm sure we're not alone in this across the province, is people who have an issue with the hospital. There's nothing much we can do, and in fact, almost nothing we can do to help them. Is this an issue too? I mean, do you hear about this?
Yeah, it is a problem. I mean, I really think that Ontarians want to see reform, that hospitals used to be governed by voluntary boards of directors that were much more accountable to local communities. There would be a banker on it, there would be a lawyer on the hospital board. The community has a definite interest in the hospital running efficiently. They shouldn't be seen as somehow the enemy of efficiency. But on the other hand, the community has a definite desire to have a full range of community hospital services available local to them, close to home. And most communities have spent the last 100 years or so fundraising and volunteering and trying to build up their local hospitals so that those services are there for people. They're seen as key public institutions. But over the years, they become less and less public. The CEOs see them as businesses. The CEOs' salaries have gone through the ceiling. They're not very accountable. It's hard to get information out of them. And there isn't very good public oversight because the boards have become appointed boards, which gives the CEOs ever more power and less accountability. And the government has increased central control over the hospitals to the Minister of Health, but diminished community accountability and flexibility. I think that the balance has shifted the wrong way in this, and that it really does violate Ontarians' needs to get answers when problems arise, and needs to access services that are being cut, and also our priorities and our values. People expect our hospitals to be public. That crosses every political party line in Ontario. They expect them to be accountable. We fund them. They expect them to be responsive to our communities, and they're not.
In case you just tuned in, we're speaking to Natalie Mehra, Executive Director of Ontario Health Coalition. We're talking about healthcare cuts in Ontario and what they mean. Now, you, I'm sure, have talked to the government when you confront them with the fact that there are cuts and that things can't keep going the way they are without significant loss of service. What do they say?
And now, currently, the response is that they understand that hospitals are under a lot of pressure. They understand that there are problems in home care and long-term care, but the budget is paramount. And it's almost as though there have been no choices made that have resulted in the cuts. We shouldn't forget that Ontario has seen the biggest tax cut in the country under the Harris government originally in the 1990s. Where we saw massive corporate tax cuts and tax cuts mainly for the wealthy. But then again, in the mid-2000s, the first decade of the 2000s, so 2005 on, we saw very significant corporate tax cuts. And now what the government is doing is trying to pay for those tax cuts on the backs of seniors and people who need healthcare services. I don't think that these are choices that Ontarians would have willingly made, but people have never been given the true story and have never been given a choice. In Ontario now, we fund all of our public services. That's hospitals, schools, the judiciary, public transit, roads, everything, parks, less than every other province in the country. These are choices that are being made, and they have consequences for people. They mean that we pay more out of pocket for healthcare services than any other province. They mean that we have poor public housing and a real housing crisis. They mean that we have greater income inequality. They mean all kinds of problems for people. Highest university tuitions in the country. People are now paying out of pocket in myriad ways for these corporate tax cuts that have not resulted in an improved economy and improved jobs.
It's interesting that you say that because I have a very clear image of Minister Glenn Murray standing up in the House bragging to the Conservatives that we spend less on all of our social services combined than any other province, that this is a sign of fiscal good management. I thought I was quite shocked by that, clearly sort of out-touring the Tories on that one.
Absolutely, and juxtapose it against the news from all these corporations that they're sitting on literally billions of dollars. They're not investing them, they're just sitting on them. And so why are we giving more tax cuts when there's a real need out there for people? There's a much more balanced way to move on this, and I realize that the public has been sort of sold this bill of goods that, nobody wants to pay taxes, but in truth, these are corporate tax cuts, and they're just sitting on the money. And instead of us having a society that is safe, that is more equitable, that provides for each other, we're just giving money away to be offshored, essentially.
Mm-hmm. It's long been said that we don't have a spend problem, we have a revenue problem in this province. Yeah. But of course, the argument, and we're veering a little off topic here, but let's go for it. The argument against that, of course, is if you up the taxes on the corporations, they'll just pick up and they'll leave. And you must have thought this through. You're not the first to have made the suggestion that we increase corporate taxes. What is your response to that?
Well, at this point, we're almost at the very bottom of all jurisdictions in North America, including Mexico, in terms of corporate taxes. So, while there is definitely, a legitimate question of what they would call capital flight, that companies leaving, we certainly have a lot of room to go before we're anywhere near that. Virtually every jurisdiction in North America has higher corporate taxes than we do. So I think that proves if everyone else can do it, why can't we? I mean, in truth, PEI spends more on healthcare, spends more on hospitals than Ontario does. These are choices. These are not necessities.
Mm-hmm. And it seems, I would add to what you just said, that in fact the reality is that they're picking up and leaving anyway. I mean, we've seen this with Future Shop, Target. We've seen thousands of jobs lost in the last 10 years. So could it be any worse? It's hard to imagine, quite frankly, right now in Ontario. Anyway, away from the revenue, we'll get back to the healthcare situation. So you've been doing this for 14 years, Natalie. Have you? Is this as bad as you've seen it, or is there hope here in this picture?
I'm really, really worried. This is the worst I've seen it in the 14 years that I've been the executive director of the Ontario Health Coalition. Before that, I was on the board, and I was the chair of the Kingston Health Coalition. And I did live through the cuts of the 1990s under the Harris government. Those cuts were very severe, but at this point, Ontario's hospitals have been cut for 20 years already, more than 20 years, actually. And there really isn't anything left to cut. I mean, there could be reform for sure in terms of the exorbitant executive salaries and the burgeoning legions of managers and bean counters in the system. Even taking that into account, Ontario's funding its hospitals at a very low rate compared to everyone else. We have the fewest hospital beds left of any province in the country on a per-person basis, so like the fewest beds left per person of anywhere in Canada. And we actually looked at the whole OECD, so that's all the so-called industrialized countries of the world, and we're at the bottom of the OECD in terms of the numbers of hospital beds that we have left. We really have cut more than anywhere else, and this means privatization. At its very base, this means that people are pushed out of hospitals without care. It means that they have to pay for care. And if you're buying personal support, it could be $25, $26 an hour. It's very expensive. It's beyond most people's means, really. To buy a long-term care bed privately can be tens of thousands of dollars. It's very, very expensive, and something that most people can't afford. And so all the problems that cause the creation of the public health care system, the suffering and the inequity, have come back as a result of these cuts. And they just, at this point, they just need to be stopped.
So you've spoken to the government, obviously, without a whole lot of impact at this point, sadly. And again, as you say, what we're hearing is just a sort of endless numbers game. We've pumped this much more money in. We've hired this many more nurses. The reality being, of course, that our population is aging and is growing, and per capita, we are paying less for healthcare, or the government is, than they have in the past. Where's the thin edge of the wedge? What do you think is going to be it seems like we're teetering on the edge of a crisis here. Where do you think that crisis will become apparent first?
I think we're actually in the crisis. I think it's very apparent if you walk into any hospital in any major town in Ontario. Every major town hospital is running at 100% or more capacity. That means all the beds are full. It means that there are patients in stretchers in hallways. It means that the emergency departments are backed up because there's nowhere to put patients into beds. It means that surgeries are canceled because there's nowhere for patients to recover. It means that ambulances are taken off the road, that they have to wait to offload their patients, sometimes hours, in emergency departments because the emergency departments are full. It is a crisis, and actually nowhere in the world, nowhere in the industrialized world do they accept that kind of level of overcrowding in hospitals. In fact, the debate in Europe is whether an 80 to 85, whether an 80% or 85% occupancy is safer. The average across Europe is around 78%. In the United States, 77%. Nobody runs their hospital system teetering on the brink of total crisis like we do permanently. And at this point, it is a crisis. It's a crisis that threatens people's lives, that causes more deaths in the emergency department, that causes higher hospital-acquired infection rates, that causes safety problems for staff and for patients. It is a crisis, and we're hoping that we just recently released a report called Code Red, in which we found that 1 in 4 Ontario hospitals has had major cuts or is threatened with closure. And we're trying to use that to really sort of underline the permanent crisis now that our hospitals are in as a result of the cuts.
I want to spend just a few minutes, because we haven't touched on it, about mental health and addictions services too, because they fall under healthcare. And there was a select committee who did a wonderful job of studying the issue, making an all-party series of recommendations. There were about 23. I think 3 have been acted on. But certainly in parts of my area in Parkdale, and others, addiction is everywhere, and so are mental health concerns. There's a real issue with getting, say, into rehab, into detox. That's always been the case, and particularly for young people as well. There's a great group called Tragically No Hip that came to Queen's Park a while back, saying, where do I go? What do I do? My daughter is suicidal, and there's nothing. We're but weightless. What's happening there? If it's this bad everywhere else, what's happening there?
Yeah, well, the government is sort of making a big issue of its current investments in mental health. What's odd is that they're announcing these investments, but we're seeing mental health services being cut all over the province. In Whitby, they've been cut. Up in North Bay recently, they've been cut. We know that there are areas of Ontario where people have been waiting literally years. There are no placements available for families who need them, particularly, as you're saying, for young people. But these services, as you know, have always been kind of the poor second cousin of the health system, just really underfunded, under-resourced, and undersupplied. And the current cuts are just making it worse. And really, it's devastating for families who need even emergency mental health services. They can be very hard to find, particularly the institutional mental health services. But also, we're seeing community services being cut. And even just last week, there was a crisis support program that's being closed down in Toronto. No explanation for it, but these are for people with mental health crises. I mean, these are emergency services that are being cut. It's just indefensible.
One of the, listeners are aware that I brought it, an anti-conversion bill got some play, got support from all party support. It was quite a rare moment at Queen's Park last week, and editorial board of the Star supports it, blah, blah, blah. One of the concerns there, and that's, of course, for a small marginalized group, those who are trans folk, but was that the only point of access for first order treatment is CAMH that's in Toronto. And if you're in Thunder Bay or, Timmins, that's pretty hard to get to. And you have to maintain yourself while you're down here trying to go through this. And this is for a community that lives by and large below the poverty line. Is that kind of an example of what's happening across the province in terms of all services in your estimation?
Yeah, for sure. I mean, that's an extreme example. And congratulations, by the way, for your work on this really, I think, important issue. I think that it's sort of the extreme example of what is happening across all kinds of services. I mean, people are now having to leave their hometowns to die for palliative care because their palliative care wards have been closed down. People have to leave town for mental health services. People have to leave town for long-term care. For chronic care, far away from their loved ones, far away from their support systems. It really does mean suffering for people. It means a lot of added costs, and for a lot of people who can't afford it, it means isolation and suffering.
Again, speaking to Natalie Mehra, Executive Director of the Ontario Health Coalition. If you want to tweet in a question, by all means, please do, or comment. It's at CHERIDINOVO. And now is a good time, perhaps, to draw your attention to the fact that next week is fundraising week. So we hope that everybody calls in and joins up to the only alternative radio station left now in Toronto. Sad to say, but happy we're it. So keep us on the air, keep us alive. And of course, if you want to Facebook me again at the same name, Sherry DeNovo, your host, MPP Parkdale High Park, please do, with ideas, comments for shows, and any questions, of course, that you want us to send to our guests. So Natalie, just a few minutes left. What's ahead for Ontario Health Coalition? What are you working on right now?
Well, we've been working on, we did a major report on home care reform, and we traveled across the province. We held roundtable meetings with patients, with family members, with all kinds of nonprofit organizations and care providers of different sorts, and all of the major seniors groups. And really what we were trying to do is get a picture of home care in Ontario and see if we could build consensus towards home care reform. At the same time, the government came out with a report which calls for more privatization of home care. And so we have, I think, a big fight on our hands to stop the privatization of home care and stop the privatization of hospitals and their care. And so we're going to combine that. We're going to do a series of large regional protests across Ontario, calling for a stop to the hospital cuts and a stop to the privatization of home care. So that will be running through May and June, and will culminate in the city of Toronto. And
when will that culminate? Do you know yet?
Well, we don't have a date yet. We're sort of looking at going around the province first, and then coming back to Toronto in June.
And privatizing long-term care, obviously we can all see that happening. I mean, that's privatizing hospital care. In what sense there?
Well, there are two things that are happening. One is just cuts. So when they cut chronic care, which is sort of the longer-term care, people are discharged from hospital and they don't have care. There's no long-term care beds available almost everywhere in Ontario. There's no home care available or very little for people in that situation, and so they just have to buy it out of pocket or if they can afford it. But as I say, thousands of dollars, can be thousands of dollars a week even, for that type of care. And so people often just go without. They really suffer as a result. So that's one type. The other is when they cut length of stay, so they discharge people very fast after surgeries, and so things like physiotherapy and the support to recover from the surgeries is no longer publicly provided because you're discharged from hospital. There's a long wait for home care, a physio, if you can get it at all. The only clinics that exist are private clinics, and they cost to be $75 to $100 for your first assessment, $50 to $70 for every visit thereafter. So if you're going 3 times a week, you're talking about hundreds of dollars a week for your physio, and you probably should go for about 6 months after a surgery, and so that's a lot of money. It's definitely beyond the ability of most people to afford. And then, in addition, the government is now talking about cutting surgeries and diagnostics from local hospitals and contracting them out to private clinics. They were going to start that last summer. We've stopped it so far, but we haven't completely won. We haven't gotten a complete withdrawal of the plan from the provincial government, so we're trying to push that over the top and just get an agreement from the provincial government that they won't do it at all. And so that's what's happening.
Okay, and in a minute left that we've got, Natalie, tell us what should be happening. We know what is happening. It's dire. We're in bad shape here in Ontario with healthcare. What are the steps the government needs to take immediately?
Well, one, we need to fund our system properly. So we need to fund it to meet population need, and we need to measure and try and meet that need. So there's no healthcare planning anymore. There's no measurement of population needs. There's no plan to have enough hospital beds or long-term care beds or home care to actually meet that need. So that's the first step. The second is that the institutions that provide our healthcare need to be reformed. They should be public and not for profit. They should operate on the values that the population has around democracy, around flexibility and responsiveness to our community's concerns. They should have high quality standards. And so those types of reforms need to be undertaken to ensure that money actually goes to care. And I think that would go a long way towards meeting the public interest in healthcare reform.
Thank you so much. It's been a delight. We've been talking to Doris Grinspun, CEO of the Registered Nurses Association of Ontario, Natalie Mehra, Executive Director, Ontario Health Coalition. Thank you, Natalie, for being on Three Women. Keep your comments, keep your questions, keep your concerns coming, and we'll see you next week. Do tune in. Will be a very special show next Tuesday, 9 a.m. on Three Women.